Recording has started.
Hello everyone, and thank you so much for attending our ID series today. We are extremely excited today to have Dr. Dorothy Dillard from Delaware State University to give us a talk about the impact of COVID in underserved communities. But before I introduce her, let me mention some housekeeping issues. So we will extend CME credits for our Tech Talks and our ID series presentation. The information will be sent by email to those that registered for today's event. But if you did not register prior to today's talk, you can still obtain CME code information from Lisa Maturo, and I'll post her email address in the chat. Our June 11th ID series will be Dr. Theodore Corbin from Drexel University, who will talk about trauma through the lens of trauma approach to stress, violence, and adversity. And we will also have a tech talk on June 3rd, and that will be Dr. Jobayer Hossein, who will talk about post hoc mixture models of the best linear and bias predictors. So two events that you really do not want to miss. So again, I'm very excited to introduce Dr. Dillard from Delaware State. Dr. Dillard is a sociologist and an expert in the evaluation of social service programs. She's the director of the Center for Neighborhood Revitalization and Research at Delaware State University. And from 2014 to 2019, she was the chair of the Department of Sociology and Criminal Justice at Delaware State again. She has a PhD in sociology from University of Delaware, and her research focuses on understanding and addressing social policies and practices that fuel social and health disparities, and on reducing the barriers to implementing effective interventions and treatments by working in partnership with community-based organizations. She's a PI or co-I on several grants from the Department of Justice, the NIH, and also our ACCEL program, and she has a grant for a strategic partnership initiative. So I'm really delighted that Dr. Dillard is here to give us a talk, and thank you so much.
Thank you, Claudine. And thanks to all of you who are joining us. I appreciate the opportunity to talk about conducting community-engaged research in underserved communities during the age of COVID. I want to focus today on where we are with the project and getting it out into the field. As a caveat, I just want to say quickly that I am in Sussex County and my internet is being really quirky today. So Lisa and I have developed a backup plan. So if I disappear, I'll call back in and she can click through the slides with me. Okay. Here we go. So I'd like in my talk to be able to help you all think about, in the context of our experience at Delaware State University, community engaged research at a little deeper level. We're all at different places in our experience and our skills with community engaged research, but we all can use the opportunity to think how we can expand our efforts in this area. I'd also like to be able to share our experience so that it will be helpful to you in identifying strategies to engage underserved communities, as well as to adjust the research plan as we go from ideal to reality. I want to start with the definition of community engaged research to create a common framework for us and a common way of thinking about it. I'm relying here on the community engagement core of ACCEL's definition of community engaged research. I want to emphasize that we think in terms of a value system rather than a specific methodology. It's about giving priority and space and voice to the community or the patient, and it is a collaborative process. It's also a journey. It's not a product. It's not a process. Even sometimes it can be a journey, and I think that you'll see that play out today as I talk about our experience. This definition is on the ACCEL website, and I encourage you all to take a look at it so we can all continue to build our community-engaged research muscles and efforts. To put all those words into a picture, I'm going to rely on community-based participatory research, where there's a lot of information in the literature for this framework or model of research. And I think what's important here with this particular diagram is that there are different ways and different points in our research where engaging the community is appropriate, is necessary, but it varies depending on our funding process, timing, the established relationships that we have, access to community, even how we're defining community, as well as community trust, interest, and willingness. So we'll see how that's impacted our study and our ability to get the study out into the field. We start out with our ideal of how we want to involve the community, and I think all of us are committed to ensuring that what we're doing is community driven so that it can be community applied. So if we look at our traditional research process in terms of that community engaged research framework, we are really wanting to have the community define the problem. But in reality, especially if we're seeking funding for our research, the problem is defined by the funding source. And our study is funded through NIH, so I'll talk a lot about the impact and kind of the defining of our process and our study based on federal funding requirements. When we're designing our study, we want to do that with the community. We want to implement with the community. And both of those are affected by and impacted by our resources in time, our resources in staff people, and our resources in funds. And that, again, is connected very closely to our federal funding and what is allowable, what is affordable within the scope of the request for proposal. We also want to include the community during our analysis process. So they may not be statisticians, biostatisticians, but they certainly can look at numbers and tell us what it means to them and their lived experience. So we want to include them there, and we want to make sure that we include processes that don't take that analysis piece away from the lived experience. And finally, in that traditional research process, we think about dissemination. And when we start to develop our research into the community engaged research framework, we want to make sure that dissemination is not just about publications and contributing to science and building our vitas, but it's also about keeping our findings in everyday people's words and understanding and views, and that we produce with community and by community the information we've gained from our research in ways that can be used by the community to continue to improve and build. So we already have, before we get started, we already have the pushback from reality and the framework of federal funding that's defining and sometimes limiting the ideal that we want to be implementing with our community engaged research. So I'm going to frame the discussion with what these realities, 4 big realities that we have already faced in getting our study out into the field. And the first reality is it takes a community. We can't do this by ourselves. I'm sure everybody who's listening knows how important that is. So in responding to a federal grant that came out in June or July, we had about 6 weeks to pull together a team and put together a proposal. So we had to start thinking about what our study population looked like, how broad we were going, how deep we were going, what would be a successful proposal, what would be of interest to NIH, what would be competitive. We had to think about our data collection tools and what we could get through our IRB. We had to think about the analysis, not only what was fundable, but what type of study population we needed, how big a sample we needed to give us the rigor that we would want in our analysis to be able to be funded. So I'm sure many of you are relating to this, that pulling all of these pieces together, getting everybody on board is difficult enough. But when you also begin to bring into the picture the community engaged research aspect of it, how in that 6 weeks do we get all of these pieces together, get this written, pull the team together, get all the bureaucratic paperwork that has to get done, get it through Office of Sponsored Programs for those of you in academic institutions, and also engage with the community. Fortunately, and this became even more important because we had some ideas about what the proposal would look like, and then we went to some of the NIH webinars and learned that there was an emphasis on community engagement and learning more from underserved communities. And so we needed to build out and expand the community engaged research aspect of it. Fortunately, my work in communities across the state of Delaware allowed me to leverage some partnerships I already had to be able to get into the communities that we were most interested in. So we brought on our community partners, and I'll talk more specifically about who they are and their role in just a minute. But we brought on our community partners. They were able to take a look at and respond to the RFP, the proposal as we were putting it together. But beyond the community partners, we were limited by time and resources and access to some of the more underserved, more remote, isolated communities, and having the full feedback from them that we had wanted. So what we ended up with is a study that we titled Social and Behavioral Implications for COVID-19 Testing in Delaware's Underrepresented Communities. And our 3 aims were to investigate the factors falling into the 5 domains of socioeconomic factors, demographics, health, mitigating behaviors, and community context, to better understand resistance to COVID testing, as well as be prepared to have a better understanding of resistance to the vaccination. Because at the time we were writing this in August of last year, the vaccine was on the horizon, part of the discussion, but none of us could have predicted how quickly it rolled out and was available to us. So I'll talk about the adjustments we've made there as I go through the presentation. Our aim in better understanding the impact of COVID in underserved communities is to reduce the inequitable burden of not only coronavirus, but also of other health disparities. Because as we'll see in the next slide, the communities most affected by COVID, most disproportionately affected by COVID, are the same communities throughout Delaware that experience health disparities and have traditionally and historically. We also wanted to identify strategies and help inform public health messaging and processes to begin to create greater equity for these communities, not only around COVID testing and the vaccination, but also other health issues. We developed a time series design with what was originally 4 data collection points. I'll come back and talk about some adjustments we've made there. But at this point, it's 3 data collection points where we're contacting our participants every 6 months. Our data collection is a serology test so that it's just the finger prick. We're able to identify whether or not the participants have been exposed to the antibody, and we also are doing about a 20-minute self-administered survey. The survey is based on Johns Hopkins University's COVID impact survey, which is also a consideration as we were developing it. How do we build on and contribute to the information that had already been gathered, and how do we present a survey that is acceptable to NIH? So we actually are using an abbreviated form of that survey that we have expanded to include more vaccination-related questions as well. So our study communities, we were insistent that this be a statewide project. We wanted to make sure that we capitalized and leveraged our Delaware experience. For a sociologist like myself, Delaware is a beautiful place to be doing work because we really are a microcosm of the U.S. We have an urban area, we have rural areas, and we also have the smaller cities. We identified the communities based on their CHI score, which is the Community Health Index used by public health to characterize communities based on existing health disparities and health resources. We coupled that with the DPH data on COVID, and prevalence of COVID, and the rate of COVID testing. And our 9 communities are ones that those of us working in this arena are not surprised by. In Newcastle County, we are focusing on West Center City, Riverside, and Northeast Prices Run. In Kent County, we're focusing West Dover, West Camden, and Harrington. And in Sussex County, Bridgeville, Seaford, and Georgetown. We are aiming to have a sample of 1,200, and that is sufficient to support the analysis model that we proposed. And thank you to Bird for a very helpful consult there and helping us frame out that analysis and identify the sample size. And then our community partners, at this time in Newcastle County, we're working with the Wilmington Hope Commission, and for Kent and Sussex, we're working with the Sussex County Health Coalition. Both of those were selected based on their role that they play in the communities that we're interested in and their ability to connect us with trusted facilities trusted by community residents where we can conduct the study. Oops, I'm going the wrong way. So a little bit about what community engagement looks like and what was feasible for us in the time frame that we had to put together the proposal and the framework that we're working in. I'm going to focus on the Sussex County Health Coalition as an example, but leveraging that they were involved with and reviewed the proposal and gave us input and talked about what was feasible. They are very familiar and actively working in the Sussex County site, but had less strong connections in Kent County, but did have a network that we could leverage there. So we were using our community partners to connect us to their network partners who then can connect us with the trusted facilities where the residents in the underserved communities that we're focused on are willing and comfortable to come and learn about the study and participate. So with Sussex County Health Coalition, 2 examples of their network partners who we're working closely with are First State Community Action Agency. We're using the office, First State's office in Georgetown, which is right there in the middle of Georgetown, and where there's lots of traffic, and people are able to walk to the site. And we also are using two of First State's community centers, one in Coverdale and one in Walker's Mill. And with Sussex Community of Hope, we've been connected to, and these are just examples. We have other sites, and I'm just trying to give you an example of how we are digging deeper and getting closer to the community. In the back of my mind, my mantra is always, our sites need to be in walking distance. Our residents need to be able to walk to the study site. So in Seaford, we're using a church, being respectful of the church. It's very small, and the parishioners were concerned about too much traffic in the church, so we are using a tent and doing the site outside. And we also are going to be starting actually next week at the Seaford Library. Seaford Library has just launched their telemedicine effort, and so that's a great place for us to meet. They also host ACCEL classes for Haitian Creole residents, so that's a way to tap into that population and to be in a place that the residents feel are safe. So reality number two, things change. Things change before we ever get out into the field. So the first thing that was a little bit of a surprise for us, we were funded to start in October, and so it was November before things started moving. We're moving along, and all of a sudden our email boxes were full of invitations to NIH collaborative groups, RADx and the engagement intervention team. So we meet monthly with our EIT team. Duke University is the coordinator of the efforts funded with this funding stream. And so we also are working with them and the Data Corps on being able to provide shared data. And I'll come back to that in just a minute. But this is where our resources get stretched very quickly. Having a team of 4 of us, I spend the large majority of my time out in the community, connecting with sites, connecting with partners, making sure that our study protocol are acceptable, and also helping with the recruitment of participants. So we are fortunate to have several other MPIs who are able to share the load of making that connection and being a collaborative partner in the NIH efforts. We were not aware, we knew we would be sharing information with NIH, sharing our data, but we were not aware that there was a set of common data elements that Duke University wanted to ensure all projects were reporting on, which is understandable and fantastic, but we were all a little surprised from a community engagement perspective that some of the common elements included Social Security number, as well as other information protected by HIPAA. And so we had to work through that with our EIT team and with Duke on what was acceptable and not acceptable to ask from the population that we were wanting to include in the study. So we were able to offer an abbreviated, a revised version of those common data elements to ensure that we protected our participants. And had to work through the data usage agreement and figure out how to revise that so that it didn't put us in a position of promising things that would be deterrent to our participants getting involved in the study. And before we rolled out into the field, the vaccine became available, and the shift in public health focus was apparent, where there was less attention to the testing and more to the vaccination and the barriers to vaccination and resistance. So we went back and took a look. We had included a few questions on the survey around vaccinations, but we went and expanded that so that we would be able to inform the public health messaging sufficiently on that piece of it. It's interesting that the being able to communicate what we're doing, why we are doing a serology test, being able to work with potential participants, interested residents, and understanding that it's not a coronavirus test, that it's not a vaccination, has helped us to connect better with them, listen to what their concerns are, that certainly we hope are reflected in their responses on the survey, but also having an informal qualitative aspect of it so that we are getting some of the more authentic and broader concerns and feedback from community members. So when we're in our sites and working, we're not just getting the informed consent filled out, taking the finger prick, having work through the survey, and then out the door. We really are spending time and explaining what's happening and listening closely as they respond. So reality number 3, our bandwidth is limited. All of our bandwidths are limited, especially in the middle of a pandemic. And this has been one of the places that COVID has had the greatest impact. Our community partners are working from all ends that they have to not only ensure that the services they were providing before the pandemic continue, but also to make sure that they're serving their communities in getting through the pandemic, addressing the support needs, not only mental health, but also around employment and housing and health care that the pandemic has created. Our trusted facilities are, many of them, we entered into the proposal and entered into the study thinking that our trusted facilities would primarily be healthcare facilities and healthcare clinics. But those clinics and those facilities have been overburdened with responding to the COVID pandemic, as well as trying to host vaccination clinics. And so we have been able to shift, and actually it's been a blessing in disguise because it's gotten us into the communities and really working out of community centers. We've had a limitation in that, and that many of our communities of interest are housing authority communities where there's still a restriction on using the community rooms there. So figuring out where we can conduct our study, what site is available that's still in walking distance, so that we are sure to include residents who live in underserved communities. And then our study team has also had a limited bandwidth. At first, we had trouble getting enough nurses on board to have sites every day, and having sites running every day, and to be able to cover the 9 different communities. So we're not in all 9 communities every day. And once we figured out leveraging our partnership with Beebe and Sussex County, we were able to bring on more nurses. We are using student interns to assist with the survey administration if our participants need help. we are also using them to walk through the informed consent, and we had lots of students interested. We trained them, onboarded them, have them out in the sites, and now we've hit the end of the school year. So we have enough nurses, and we're getting creative with our recruiting for more interns as students take the summer off. The reality number 4 is all good things take time. And I think that this is one of the core values of community engaged research is to be patient. One of our examples of just staying steady and not off track is in our Coverdale site in Sussex County. We're in a community center there, and the community center is at the front of the community. And so we went and we had set up and we did the recruiting and got the word out, and we sat for 3 weeks before anybody showed up. And one person showed up, and it happened to be a long-term resident of the community and somebody that we would consider an influencer. And she said, "This is not at all what I thought it was about." And we talked with her, and she participated in the study, and she realized how important it was. And the next week we had 10 other people there. So being patient, making sure that we let the community know that we're there, that we're serious, that we want to work with them on their time, which for a 2-year study is sometimes a little nerve-wracking when we see that end and want to make sure our sample size is sufficient for the kinds of analyses that we want to do. These are the sometimes contradictory priorities that we have with this type of research. But our influencer emerged there, and we're finding that in some of our other sites as well. So we also need to be flexible when we're doing community engaged research. With this study, I think that because we are in communities, we saturate the participants in that community, the participant pool in that community at some point, whether it be 3-4 weeks or even a couple of months, and that we need to be prepared to move with them and move into other communities as we saturate. So when we go back to do the follow-up, we'll go back to the same communities where folks were when they did their initial survey. Adaptability, here I talked about some of that even before we got out in the field and really building out the vaccination aspect of our study, adaptability to work with NIH and their different groups that they wanted us to collaborate with. But we've also had to be adaptable in the field. We had a site who had experienced, they provide services in the site. They had experienced a very traumatic shooting where one of their clients had been killed, as well as 2 family members. And so it made sense. We had to be willing not to be there at our next scheduled time, to be able to let the facility and the folks who receive services there work through that really traumatic experience. So these are the realities of the communities that we're working in that we need to be respectful of. And then we also need to get creative. Every day, every week, the project manager and I talk about new creative ways that we can recruit, that we can find facilities, that we can get closer and closer to our participants to make it easy for them to participate and to keep this community engaged. So I think two of the examples there, we have done recruitment coordinating with First State Community Action Agency as well as Sussex County Health Coalition. We have been able to do recruitment through food boxes. So when the food boxes are distributed, there's information about the study and where they can participate in it in those food boxes. Our recruitment is tailored to the communities, and we just try to make it as easy as possible for them to participate. And then the other creative thing that we've implemented is the tent, and having the tent and having outside study sites available that for communities where we're not able to get into the community room yet, as well as for our churches who want to support and help us, and also are being respectful and responsive to their parishioners and you know, who's coming through, and also for those who still have concerns about closed spaces and COVID, as we all should, we're able to provide another option for them. So back to the learning objectives and the takeaways, and just some points that I want to underscore, and hope that you've been able to see some ways for you to continue to build on your community engagement efforts. I think that understanding and growing community engaged research is, at the end of the day, about always being connecting. So whether it's connecting with our professional research, science collaborators, connecting with community, connecting with new partners. So for those of you who are movie buffs, this is a nod to Glengarry Glen Ross, and for those of you who are SNL fans, it's one of my all-time favorite SNL skits, giving a little homage to that. Identifying strategies, I tried to focus on the importance of being in the community, being predictable and reliable, being patient. Many of these communities have been promised things and have a history of not receiving, and people, you know, saying this is for you, this is good, and not delivering on that. So sometimes just consistency, predictability, waiting for them to come and learn. In all of our communities, we have influencers, and so when we sit and wait and are patient and understand the skepticism in the community of research, of medicine, of those factors throughout history that haven't always been kind to and respectful of the study population that we're working with, the influencer will emerge, and they will help us if we are authentic and present. And then finally, I hope that I've been able to describe some strategies to adjust the research plan. I think most of us who are taught the research process and have skills in conducting research, we very much want our design to be implemented with all the integrity, and I'm not suggesting that we don't keep our attention toward fidelity of our design, but with community engaged research, when our laboratory is out in the world and people living everyday lives, we need to be able to make those adjustments, be responsive to the community needs, and also be a responsible scientist, and be able to take advantage of, in a positive way, take advantage of being in the community, and as things shift and change, for instance, the vaccination, being able to use our our presence out in the community to build understanding and science there as well. So that concludes what I wanted to share. I don't know if there are questions or comments or other things people want to share as we're all working together to expand our and deepen and broaden our community engaged research.
Thank you so much, Dorothy, for this very thought-provoking talk. I learned a lot, and this is really interesting. I think we have some comments in the chat. So, and if anyone has questions, please go ahead. Shall say thank you?
Hi, thank you, Dorothy. This is Alicia. Thank you very much for the presentation, and it's a very interesting study. I do have a couple questions. I'll ask both of them, and you can decide which you have time to answer. So, one, I'm wondering if you could share a little bit more about, the engagement of community partners as researchers, in how they were involved in the research process. And then the second question I have is around what you guys have planned in terms of returning results back to both the communities that have been part of this work, but also the individual participants.
So those are both great questions. Thank you, Alicia. In regards to the community partners being researchers, I am completely committed to that. Unfortunately, we weren't able to implement that to the degree that would be considered community engaged research because the time span, the turnaround on the proposal was so short, and then the time span for the study is only 2 years. And so the training that's necessary, the time, and the other reality is that our partners are so stretched right now with the services that they're doing. So I look at it as a way to make those connections, to bring them in where we can, and to rely on them and be responsive to their knowledge and their input, so that when we have the next opportunity for research, we already have that one step deeper into community engaged research, and to be able to bring the partners and residents who are interested into the full research role. So one of the other, to your second question, one of the ways that we can deepen the community engaged research aspect is around analysis and dissemination. And so we have plans to fully involve not only our partners, but also to ask them
Dorothy, I think we lost you.
Might call back in.
She might just call in. It's good that it didn't happen during the presentation.
The question that broke the connection.
Yes, Alicia. Lisa, do you know whether she's trying to call in?
Yeah, she has the phone number, so she may be trying to dial in right now.
If you have her cell phone number, that might be worth sending a text message.
This is Marlene. I just sent her a text.
Oh, okay. Thank you, Marlene. Thank you.
You're welcome.
I appreciate your comments, Marlene, in regarding the PAR participants and SPSS, but it was a much longer study, right? I mean,
Okay.
it
And
seems.
I'm sorry.
No, it seems to me, Yasser Payne has done a fabulous work there, but he had a much longer time to be
Okay.
able to train his interviewers and his, I mean, the people who are doing the research. It's
Okay.
extremely impressive, the
Yes.
work he's done.
And
I'm back.
they were paid as well.
Right, right.
So that was the question that I wanted to ask to build on, Alicia's
Right.
question.
Dorothy, are you back?
I am back.
Okay, so I'm sorry. Please.
I'm going old school now. But,
Okay.
yes. So thank you, Claudine. I think you answered that question well. I imagine that Marlene's asking about participatory, the PAR model that Yasser Payne
Right.
uses. And yes, that was what my point was that sometimes we're not able to implement the more expanded community-based research, but we can use opportunities to set that foundation so that we can get deeper into the community engaged piece. So that's a big part of what our plans are. But just given, especially in Kent and Sussex County, where there's a lot more development and relationship building that's necessary. And a 2-year study, we just weren't able to factor in the training that's necessary to have community folks part of the research team. So we are committed to that and we want to do that. But I think that that's part of what I wanted to communicate with this presentation, is that we can't always have all of those aspects of community engaged research due to timing or funding or other types of things.
Right. So I think you were interrupted when you were answering Alicia's question regarding dissemination and how will you disseminate back the results of your study to your participants?
Yes,
and
so
to the communities.
We have in our proposal, and we have already part of our MOU with our community partners is around playing a role, a guiding role, a lead role in looking at our findings as we start producing it and helping us to interpret those so that we ensure that we have the community context in our interpretation of our findings. And then also we are committed to working with our community partners, their networks, and study participants on how to disseminate that information, not only back to the communities, but also to public health to help inform messaging and hopefully impact how we provide our health services. So I don't know if that answered the question, Alicia, and what we're doing there. But yes, that's where we will have full participation and lead by the community partners, their network of partners, and then study participants.
Thanks, Dorothy.
Dorothy, hi, this is Mary Colnane. I have a quick question. This was a fantastic talk. I really enjoyed it. I have a question about, you build relationships with community, you're working with community. When you secure funding for a study like this, do you also begin to partner with state officials who may be working in the public health arena and or other academicians within the state as well, just to in either collaboration or at least communication about what you're doing?
Yes. So as far as the state goes, I mean, because we want to help inform public health messaging, we are from the beginning of the design and the proposal working with Lisa and Carol at Public Health to help us identify the communities and to use the opportunity presented to us to work into some of the communities that Public Health has had a little bit tougher time getting into. So yes, we on our advisory committee, we have two advisory committees. One is more science focused, and the other is community focused. So we have those partners on both of those committees, and they will continue to play a role in the study.
And how about with other academicians who may be doing similar research or at least research in this arena?
We're certainly open to that. We are connected with other researchers out of the other institutions through the NIH collaborations that we're working with. So there's that connect. But that's part of the reason that I share this information, when I can, and to take that opportunity to let people know what we're doing so that we learn more about who else is working in the space. We made a connection. One of our other departments has got some funding to help with vaccine messaging, which makes sense for an HBCU to be involved in that. And so they will be we've already coordinated with them to provide them data about what we're learning about the resistance to vaccination and testing to help them develop their messaging. So we've already, made that very direct connection about how to take the findings and use it for that action research piece of it.
Thank you.
Well, this is Marlene. Thank you for the presentation, Dorothy. And I think people now know that having gone to the Citizen Science Conference, as well as the work that we're doing, on top of the fact that our project now seems to be a platform, for other CTR projects to have a community engaged component. I really do think it's important for us to be an advocate for RFPs that enable full and complete involvement of community, including being trained as researchers and to be paid, particularly since we now have models that show that can in fact happen. And, recognizing a factor about which I did not realize helps to determine the extent to which community can be, fully engaged as partners and partner scientists and experts. But I think we really have to do what we need to do to make community engaged research real.
Thank you, Dorothy. We haven't had a chance to work together
So that's
formally.
my comment.
I'm sorry, Marlene.
No problem.
Thank you.
But great presentation. Great work, Dorothy. Thank you.
Thanks, Marlene.
Thank you, Dorothy, for your presentation. Look forward to working with you in my former role at Christiana Care. I was out today with the barbershops, and just the importance of community engagement is an ongoing process. You can't just go to them when you need something, but the importance of being available to them so that it's a mutually beneficial relationship. So thank you for highlighting many of those points.
And that's our intent also, especially in Kent and Sussex counties where there hasn't been, I mean, in Wilmington, Yasser's been there, Daryl Chambers has been there, WCAC has been there, so there's they're further along the developmental pathway to fully engaged community research. And so that's one of the things that I wanted to make a commitment to, is taking the opportunity we had with this NIH funding to start that process, and also to sustain it. So it's not, we already are discussing how we at DSU can stay in those communities and continue to build our relationship and trust with them. So it's not just go in, get the study, get out. We are working on how to use this as a starting point and build that capacity, particularly in Kent and Sussex counties.
So Dorothy, there is a question in the chat from Gwen Angalet. Thanks, Dorothy, for a very interesting presentation. Are you able to share what you are learning about vaccine resistance?
That actually, we are hoping to have some information in June. We just looked at kind of how much data we have, and we are looking at that right now, and that's the first thing that we're going to provide some information on, because that's timely. And so we're expect something. Gwen, you're on the top of my list of people to let know what we know.
That's great, and we all can't wait to hear about it. I'm sorry, Gwen, you wanted to add something?
I did. I just wanted to thank Dorothy for keeping us in mind, because we're out there, Dr. Lee, and many of us are out there trying to see what we can do to help people make informed choices about getting vaccinated. So all that information really helps us.
Thank you. Any other question? Well, I have a question, so if no one else has a question, I will. So, Dorothy, I was very interested in the comments that you made related to the common data elements and what Duke wanted. And did they tell you why they wanted the social security numbers of the patients?
Well,
of
yes.
the people, not the patients.
I was shocked. We were all shocked when the common data elements came back. We were like, I was just surprised coming out of Duke University, to be quite honest, that there wasn't a greater sensitivity to, who we wanted to engage in the research, and the need, to make it safe for them as much as we could. And I mean, those are like the basic research and marginalized or underserved communities 101. So I was very surprised that out of Duke University, there was a request to provide social security numbers, and they wanted them to connect to other health data, which made it even more concerning. But we were able to work through that and to continue without having to provide that, and they were open to that. But it was quite surprising, and took up quite a bit of our time to talk through that. I probably took the lead for our team and was unbending and relentless about how that was just not going to happen.
I understand.
Because the study is too important. I mean, it is important on a national level, but it's also really important. Oh, I apologize. It's also, for me personally, even more important for the communities where we're working in the state of Delaware. So but we were able to work through that with them. But it was quite shocking.
I understand. And so the other common data elements that they were requesting, were they data that you were already collecting and they wanted them under a specific format, or did you have to add to your questionnaires?
We did not. The ones that, because we refused to add the ones that created problems with protecting, the human subjects protections, that we did not have to add any, but that was Dr. Goodman, and some of you may have heard her presentation, the last presentation, I think the last one in the series, the most recent one in the series. She's our data lead, and we just had to go back in and do some recoding and make sure that that our variable names were the same and the same format and all of that. So it wasn't a huge addition for us, because actually I think all of the variables were included in our data set.
Okay.
But yeah, it just was using their format and their response categories.
Right. So they wanted to have some type of a common data model so that they could merge all the data from the different sites.
Yes. And I have to also give a plug for REDCap. We are coordinating and using REDCap as our data collection
That's great.
format.
I'm glad to hear that.
Fantastic. Yeah.
So Dr. Chen has a comment in the chat also related to the sensitivity about Social Security numbers, and I totally agree, which is complicated. Any other comments or questions for Dr. Dillard? All right. Well, thank you so much. This was a really wonderful presentation, and we have to schedule you, in a few months to know more about the results then.
I would love to do that, and thank you very much. I appreciate the opportunity to keep working together with all of you all who are here to strengthen our community engaged research and strengthen our network and our collaborative efforts.
Thank you so much. And we'll keep in touch.
Yes. Thank you. Everyone have a good weekend.
All right.
Thanks
a lot.